Welcome everyone to this episode of your Freedom Hub's Free Market Cash Patient. Exciting times are here today. We definitely are here for you, Jeff Cantor and Charles Frohman, and you'll see as we are sponsored by the Marketplace for Health, Wealth, and Freedom, and it's definitely intentionally the disruptors intersection. Now, we are recording these for posterity, but before I tell you that, I just forgot for a minute to back up for a second and remind ourselves that we got a problem, and here it all is in pretty black and white. So we definitely like this representation of the issue we've got going on and how we're trying to make sure we fix that. We're definitely taking advantage of this app. We'll take a little detour over there in a minute. Here's the site you want to come to, this wowadvocates.com, just to learn a little more. And then again, we're going to want to come to the site. As I said initially, we are recording these. These are the various channel links on all these different platforms. I know you may like one over the other, but hey, you know what? Go to all of them and subscribe to this show on all these channels. We need that distribution in terms of these platforms paying attention to us getting these messages out. So we've got some pretty organic growth, but we'd like to try to deliberately drive some of it. And if you want to keep getting notices about these weekly shows, then use that topmost link and subscribe. So let's take a peek at where this stuff's hiding out for a minute, as I said. So if we come over to the Marketplace for Health, Wealth, and Freedom, MP is an acronym for it, mphwf.com. You'll end up on our homepage. There's a ton of great stuff with all these various drop downs you can sift through, but let's just focus on a couple key ones. We do have the one that's related tonight with the shows that we have, and I'll come back to this in a minute. As I said, we are having this revolution in healthcare. This is under the health first tab. There's a couple really good ones here, but you'll see. But it's really important. What we're trying to do is allow consumers and doctors to connect together directly. So this is almost like the Amazon for finding and connecting with a doctor and buying services and stuff. They're going to post their best cash price. So now you can see apples for apples. Hey, Dr. A, B, and C are all like a block away from each other. And wow, look at this price difference. I like this one. They got good ratings and all the rest of that good stuff. And bang, I can book it direct. And I get to kind of control, and they're bidding for my business. So it's the market for the first time. It's really quite good. And then under the Freedom tab, we've got the Fighting for Freedom. Well, guess what? It's under assault all over the place, not only in healthcare. So we've kind of cultivated some very select organizational things you should follow up on, because we're tying to all these different organizations we keep adding, and there's a lot of issues that they're all kind of specializing on, but you need to react to all of them, sadly. And then there's some videos and stuff you can scope out at the bottom of these that are all quite good. So, but let's talk about how these shows are explored, and we'll talk about tonight. So as you come onto the homepage and click on webinars, you're over on this page. It gives you a little rundown on the program, the guests. Earlier we had one, the one we're going to have right now we'll come right back to. The one we do on Thursdays typically, although we're missing tomorrow, and this is the one related to getting your money under control, and then a list of the people upcoming. And then here again, here are all the links. So you didn't have to necessarily remember all those. You can just come back here and click on these links, and the whole archive of all the videos are here for you to find. And so let's see how we do it. Here's tonight's guest, and here's where Charles comes into play. So if you will.
That's right, Jeff, and welcome, Dr. Westbrock. David is an endocrinologist, so he'll help patients with hormonal and metabolic disorders like the thyroid and fat cell metabolism, hormonal dysfunction. He's a clinical professor at Wright State University, and for a couple of decades, he's been a medical information technology entrepreneur as a vice president of InPhase International. What really intrigues Jeff and me about his LinkedIn network is this Consumer First Health Network, which, using a digital medical marketplace, kind of aims for the same thing, Forbes featured Jeff and me for, that's empowering patients to really facilitate that doctor-patient relationship, and work on minimizing the aggravating role of third parties, whether insurers or institutions. And David has written a book about that, a new dawn of healthcare, his vision, and he really has pinpointed the insurers, and he calls them mercantilists, a term I love. Jeff and I are big time political activists, reformers, and that's a bad word in economic history. The mercantilists, they're the ones who want to use government to gain the system for their own advantage. And I think a lot of us might agree big insurance companies have used government to oligopolize or cartelize, or whatever word you want to use, control the system to the hurting us through our pocketbooks and choices. So looking forward to David's presentation tonight on his book, how we can fix this problem with the mercantilists.
All right, terrific. Well, thank you both, Charles and Jeff, and appreciate that you all have joined us. I will tell you, I have had a passion for medicine since I was in medical school back in the late 60s, and it's continued right up till the present. What I've seen, though, is a significant difference, a change in medicine. And that is that the doctor and the patient have been separated. There's been a chasm created between the doctor and patient, who used to be in control of things. I think during my training years, my early years in practice, that was the golden age of medicine. You see a patient, you would render a service, and you'd be paid for it. There was some interference, but not significant interference by the federal government. But the mercantile factor was that several years ago, 30 years ago plus now, people realized that 16% of the economy was healthcare, and they said, gee, some of the business folks, particularly insurance folks, said, hey, we need to get a piece of this. And now they have not only a piece, but they have control. And what I think we talked about the mercantile aspect of this. Mercantilism, as it's the relationship of government with a company. Back in merry old England, the king put his stamp of approval on a scotch or a wine or whatever, and that stamp of approval meant that you should buy whatever product the king put his stamp of approval on. So that's mercantilism, and that's what we have now, because now we have big insurance, big hospital, big pharma, and big government. They control what medicine is all about. So who is left on the sidelines? Doctors and patients. So I'm going to go into my PowerPoint here, and I'm going to skip around a little bit because there's an awful lot to cover. I can't really cover everything, but what I'm going to do is try to tell some stories, give you some of my own thoughts about this. Well, this is my book. I wrote it it's been about 2 years ago now. I have not been in active full-time practice for about the last 5 years. So I decided to write a book and start a company. Basically, this is an idea that is based upon the fact of what medicine was like when I was, as I mentioned, in training, and when I was early in practice. The golden age of medicine, we had tremendous technology at that point, and we had doctors that really cared. We had hospitals that really cared. And I'm looking at public health and hospitals. Public health used to be for the public. Now public health is a bureaucracy. Hospitals and schools used to be religious institutions, were started as religious institutions. And of course, are now public schools. Nothing wrong with public schools, but religious institutions now have kind of gone in that direction. So we look at hospitals. Most hospitals, and hospitals in my area, were started as religious institutions, where they're Catholic, Jewish, Methodist, Protestant, those all. We had 4 hospitals in the Dayton area, 5 hospitals, And they all started as religious institutions, and now there is very little religious background. They're all now not-for-profit corporations. So I look back at the days of the polio pioneers, of which I was one. I could be one of those kids there back in the early 50s when polio was a scourge. And you had doctors who would line up at school, and that was public health. But things have certainly changed. The small hospital that used to be staffed by nuns and caring nurses now are huge, beautiful institutions. This is a hospital in Dayton, Ohio, that's Miami Valley South, is part of Premier Health Associates. We call this institutions now the Taj Mahal. Now we call it that, as you look at that, it's beautiful architecture. If you go inside any of the hospitals, any of the newer hospitals, you see they're beautiful. They have piano players, wonderful services other than healthcare services, so that it's everything for the consumer. The problem is, and this particular Premier Health bought one of the religious institutions called Good Samaritan Hospital back in the 80s, late 80s. The hospital decided to buy this religious institution by the name of Good Samaritan Hospital. And the FTC called me and said, and I said, well, I don't think it's a very good idea, because I think what they will do is they will close it, because that's competition for them. Now, Good Samaritan is a hospital where I was born and where I worked, actually. 20 years later, it was closed. Now, that hospital sat in the middle of an area that took care of the population that was the poorer population, people on Medicaid, people who had no insurance at all. And they decided to close that to build another hospital out farther north with a better payer mix. And so that's what we're seeing with hospitals. As I said, I'm going to be jumping around. Hospitals, in my thoughts, have lost their mission. The mission of a hospital is to take care of the sick. Now, if you look at hospitals, their mission is to make money, to see how much they can make for building new centers, new hospitals, cutting into the competition that they have. And so now in Montgomery County, Ohio, we have 27 emergency rooms. And why do we have 27 emergency rooms? Well, because they can charge a facility fee. Emergency rooms now are able to charge a facility fee, just as if they were on-campus hospital emergency rooms. Now, the law was changed. However, emergency rooms were exempted from that. Doctors' offices now have to be in close proximity to the hospitals. You know, hospitals systems are now employing doctors, and we'll get into that. But I wanted to get into the creation of the health maintenance organization. You remember the old term was health maintenance. Well, it's no longer a health maintenance organization, because that would have assumed that they were really going to maintain health, which they don't do. They do charge and they do ration care, but it has little to do with health maintenance. It has all to do with managing care, which they do quite well. Well, the story here, you see Richard Nixon with the notorious Haldeman and Ehrlichman. And they actually were discussing the idea of federal legislation for the HMO. And Ehrlichman says to Nixon, he says, you know, Mr. Kaiser's got a great idea. He started a Kaiser health maintenance organization, and we think it's a good idea. Well, the president looked at him and said, well, I don't know that's a very good idea. It looks like that's kind of anti-free market. And he said, well, actually, they are doing well with rationing care. And bingo, that did it. So Richard Nixon and the White House then got into the business of sponsoring legislation that went to Congress and became the HMO Act of 1973. Interestingly enough, people weren't interested in the health maintenance organizations, even though the larger companies were forced to offer an HMO product as a menu item to their employees. Nobody was signing up for it. So they increased the incentives a little bit, and gradually people didn't have to pay anything, of course, indicating that there's little value if you don't have to pay anything. That, you know, the old idea of value versus cost, well, those were removed. And so the HMO Act over the period of the next 15 years grew significantly because of those incentives, because of federal pushing in that direction, and of course offering HMO products in Medicare. I'll go back a little bit to Medicare. When you realize, you know, Medicare goes back, Roosevelt was talking about a national health plan, and he didn't do it because he was afraid that it would interfere with Social Security. But when Truman became president, he tried to push it unsuccessfully because he had a Republican Congress. And then subsequently, JFK, one of the worst speeches that he gave during his presidency to a union group was on the idea of national health because he didn't really believe in it. But when Lyndon Johnson created the War on Poverty, he said, we're going to put this through Congress, and so he did. When people didn't sign up for Medicare, he brought the insurance executives into his office and he said, gentlemen, we have an insurance plan for those over 65. From now on, you will cease to offer medical insurance to anyone over 65 because it was very popular. People didn't sign up for Medicare until that happened. Well, there's the heavy hand, there's the mercantilism, there's the association with the big insurance companies that were ceded to the big corporations, big insurance companies. Now, I promise I'm going to skip around I'm going to do, but you know, if we go to Medicare, when we go to government sanctioned healthcare, we get into this alphabet soup. Many of you may have seen some of these. I have probably dealt with most of them. Some of them are more recent and actually really more nefarious. I'm going to concentrate on some of these that you see, the DRG and the RBRVS. RBRVS was a plan designed in the Soviet Union, believe it or not. And when the Soviet Union fell and the Bush administration reached out to the Russian government to see what their plans for healthcare, among other things, were, they noticed that they had a very good system for rationing care, for price controls. And so what was created was the resource-based relative value system, where every doctor, based on geographic locality and type of specialty, was given a value. So your value was not to your patients, your value was to the system. And so therefore you were given relative value units, and those units are still used to pay you through Medicare. The other thing I wanted to talk about, let me handle this a little differently because I have a little trouble. When we look at the DRGs, diagnostic related groups, hospitals were just, it was decided they didn't want to pay hospitals based upon length of stay. They were going to base it on diagnosis. Well, great idea of government. You know, they always have the solution, right? So how did hospitals handle that? Well, what they would do, when you would sign a chart, when you'd go to medical records to dictate your chart, gee, the medical records librarian would come to you and say, doctor, you know, you have this diagnosis, this. Don't you think that this is a diagnosis here? Did you see that? Did you consider that? Now, most of the time I'd send them scrambling because I think that's fraud. I'll tell you, I'll give you a diagnosis. There's a diagnosis that we used to make called renal failure. We had acute renal failure and chronic renal failure. Now someone comes to the emergency room and their kidney functions, two that we look at mostly are the BUN, the blood urea nitrogen, and the creatinine. And in many instances, the patient had pneumonia, they were dehydrated, they had a bowel obstruction, whatever they had. Oftentimes their blood work would show that they were dehydrated. And that dehydration was an increase in the BUN relative to the serum creatinine. Well, we called that pre-renal azotemia. It wasn't a diagnosis. It was a condition based upon what their underlying disorder was. But now, most times you will see someone signed out as acute renal failure, which is a fraud. But again, that exists, it's out there. I've seen it countless times. The DRGs then have been also changed specifically because that, and diagnostic lists include things like not diagnoses, but symptoms. Okay, so how does the government handle things? Well, here's a case in Great Britain. The National Health Service decided that people were waiting too long in emergency rooms. So on high, the British system came down with the proclamation that no one will wait in the emergency room beyond X amount of time. So how did the hospitals handle it? What they would do is they simply wouldn't bring patients from the ambulance into the emergency room. And this is a typical example of what you would see in a British hospital system waiting for admittance into the emergency room. So this is just some of the problems that we're seeing. Now with Medicaid, you know, Medicaid for all, Medicare for all becomes Medicaid for all. If you're talking about everybody gets free health care, free medical care, our good old Senator Sanders and his ilk, this is what you'd see. Everybody's going to be in line. Nobody's going to get adequate care. How many doctors are going to be needed to serve a population of everybody now wanting to go to the doctor? It just isn't going to happen. Now, I'm going to talk a little bit about this as well. The Medicare, the Centers for Medicare and Medicaid Services, in its great wisdom, you know, has this system called the ICD-9, which is now the ICD-10, right? So that went from, I think, 20,000 codes now to, let me see, 87,000 codes in ICD-10. And some of the codes include things like water skis on fire. Now, I'd ask any of my colleagues, how many patients have you seen who suffered from their water skis on fire? Or how about struck by an orca? Or how about trauma from collision with a spacecraft? I kid you not, these are actual codes that are in the ICD-10 code book. Now, somebody may have had been watching the Three Stooges of the Marx Brothers, but frankly, that's what your federal government is doing. Now, if we look at Medicaid, for instance, in terms of state expenditures, this is total expenditures. Now, this only goes up. This graph is from 2005. In the state of Ohio, Medicaid expenditures now exceed 50% of the state's budget. 50% of the state's budget plus. This is unsustainable for any state. And with Obamacare, of course, federal government took that, but they were going to return it back to the states after a 3-year period. So as you can see, this doesn't work. And of course, this is Obamacare. This is the government on steroids. And I know you can't read that, but I don't want to read it anyway. This is the complexity that is the government. This is chaos. So again, I'm kind of skipping around, and I talked a lot about Medicare, but what I'm getting to is through all of this and through all the changes, including now with MACRA, which was replaced what was called the sustainable growth rate. Doctors were paid based on the federal budget, called the sustainable growth rate. That was how you paid doctors, based on whether or not the economy goes up or it goes down. Well, healthcare doesn't depend on that. So what's that going to do to patient care? What's that going to do to the number of or the amount of care that a patient gets if this doctor isn't going to be paid? And the doctor says, well, I'm not going to do Medicare anymore. So this is the great wisdom of the federal government. So 10 years ago, I decided that I wanted to start a business that would bring medicine and the control of medical care back to the patient and the doctor. Who decides quality? You know, you have the AHRQ, which is the federal government's great agency to decide what health quality is. And not only that, but that's a sanctioning agency. So it's a sanctioning agency that will go after doctors for not making a mistake, but for either coding errors or a mistake in what their thoughts on high come down to. And then that is a part of the permanent record. It's public record. And there is no way for a doctor to go back and to have a day in court, because there just isn't any. Anyway, so I decided that I was going to create a digital domain that was concerned with healthcare. And so I said there were 3 things that were important. Number 1 would be competition. Number 2 would be transparency. There is no transparency. You know, the hospitals are supposed to publish their charges. Just try to find them. And 3rd, personal responsibility. You know, patients need to have control of their healthcare dollars. In order to be able to make judgments on healthcare, they need to take the responsibility, but they need to have the power to do it. So what I decided to do was to go out to businesses, especially self-insured businesses, to have them adopt a health savings account or flexible spending account if they wished, but health savings accounts are certainly much better. That would give an individual the economic power to do that. And under the Trump administration, that was moving forward at a very rapid clip. There are bills in Congress now to extend the amounts that a family up to about $18,000. Ohio Congressman Warren Davidson is sponsoring that. Ted Cruz has a similar bill that would allow health savings accounts for other than just businesses, as the president has done with an executive order already. So this was working right in our wheelhouse in terms of what I wanted to do. So a patient can come to our website, choose a doctor from a list, and look at the costs of what they needed. They needed knee replacement, that they need hip replacement. We wanted to encourage outpatient surgeries. You know, we talked about hospitals and the facility fee. Another great aspect of mercantilism is the fact that hospitals are given 3 to 5 times the amount of doing a procedure in a hospital setting or outpatient setting than a private practitioner. I do thyroid biopsies, make diagnoses based on whether the patient has a benign lump in their thyroid or whether it's not benign. And I've done that hundreds of times. If the patient goes to the hospital, they get gowned, the radiologist gets gowned up, comes in, and it's about 5 times as expensive. So we think not only can we save dollars for the patient, for the self-insured company, but we can also improve quality, because that doctor who knows what he's doing, for instance, I saw my own physician, my own cardiologist had a private practice. I could go in very conveniently, see him on a Friday morning, if I needed an ultrasound, have a treadmill with a scan, and all that was very efficient with a very low cost. He couldn't afford to do it anymore, and now he's no longer in private practice. So I'm looking for the private practitioner, private primary care physicians, internists, those surgeons. I'll give you an example. I talked to a surgeon several months ago, and I said, in fact, I saw him as a patient many years ago, and actually just recently when I had the tendinopathy, an Achilles tendinopathy. And I said, Frank, why don't you and your colleagues set up an independent ambulatory surgical center? I said, you have companies that will do everything for you, manage it, set it up, do everything. And he said, I can make 5 times as much in the outpatient center, which is off campus from the hospital. I can make 5 times as much as I could in an independent surgical center. That's where the cost is coming, and the quality is no better. In fact, we think that it may be a little worse because the surgeon is going to be under the gun by the hospital's rules and regulations, which, of course, if you're a physician that doesn't get along with the administration, you may be termed a difficult physician and be brought before the committee, and then your privilege is taken away. So there are problems with hospital practice, and because the morale amongst physicians in hospital PHOs, the physician hospital organization is a great idea. Back in the 80s, we attended a meeting, and the administrator got up and talked about this wonderful thing called the PPO, and that the hospital and the doctor, we wanted to package everything, and we're partners, right? Well, we're actually their clients. We were in those days. When we looked at the fee schedules that they were putting out, guess who would make the most money? It was those doctors who spent most or all of their time in the hospital, surgeons and particularly procedurists. So we canned that idea, but of course it came around, and of course the federal government put its imprimatur on the physician health hospital organization, which is really the hospital physician organization. Physician is an employee, even though they're supposed to be, there's not supposed to be the corporate practice of medicine. Frankly, the hospital controls everything. Listen, I'm going to stop now because I think we're about 15 minutes. Am I right, Jeff?
Yeah, we're doing good here. We should definitely take a quick break. And that was a lot. And needless to say, you could just keep pouring it on because there's
I tell you, there is so much.
We could talk about every box on that chart you've got on this.
Yeah, exactly. I'm going to take that off because
imagine how many people does that represent in organizations? Does that really represent?
Thousands and thousands. What we need is a bigger federal government. We need more federal employees and more people in cubicles that control your care. And that's what it's all about. This is all about control. It's all about money and control.
And as a good example from that description you just gave, out of the number of doctors that there are, how many people are there on the administrative side?
Well, let me give you a good example of that. The system that I mentioned earlier, Premier Health, guess how many vice presidents they have?
Go for it.
112.
Oh, that's a good round number.
112. Now, this is not a company that, or a hospital system that has, far-flung other hospitals like some do. They're generally in the greater Miami Valley area. 112 vice presidents, and the administrator received a $20 million loyalty bonus just about a year ago. $20 million.
Oh, not too shabby. Certainly love to sit on those Zoom meetings, with 112 people on there. Got
Well,
some
that's
cool.
where we've got to get into. The cost of healthcare has little to do with what doctors charge. It has a lot to do with what the government allows hospitals to charge. For instance, if you happen to have the COVID curse and you're hospitalized, many do not know how much, if you have to go on a ventilator, how much the hospital is paid by the federal government for that. $37,000 per ventilator patient. $37,000.
Looks like everybody that might sneeze might need to get on a ventilator.
Well,
Kind
would
of a
you be a
thing.
little bit worried that if you went in the hospital and didn't need a ventilator, that maybe they would intubate you and put you on one anyway?
Somehow
I'm not saying that, but certainly the financial incentive
is
would push you in
definitely
that
is
direction.
definitely pushing the wrong direction. Absolutely.
Exactly.
Well, let's get some questions. So everybody just use their raise hand icon, and we got some up already. So Charles, I see you got yours up. So let's kick it off.
For sure, Jeff and Dr. Westbrock, great presentation. I love it when scholars like yourself give us some tidbits from the past that are critical to understand how we got this edifice, this cartel that we're stuck with. For example, knowing that Medicare's monopoly for the elderly came from a threat for the insurance mercantilists to drop coverage at age 65. That's something even we do with our Forbes featured sharing HSA plan, which is great, but at age 65, you got to give it up. And of course, for Medicare, and of course, Medicare has built in other incentives that you know about that penalize you for late enrollment.
Absolutely. In 1965, the life expectancy was not that great. Now we're talking about near 80. So you're expected to live 15, maybe 20 years beyond the previous life expectancy, which is why there is a $57 trillion infinite horizon in Medicare costs. That is the infinite horizon for Medicare. 57 trillion. It's unsustainable. This can't go on forever.
And if I can follow up, Jeff, a couple of things. I may have missed it, but continuing your description of government imprimaturs on novel ideas like Nixon's HMO Act, what was the incentive that government added to encourage employees to select the offered HMO plan that was not popular?
It became cheaper. If you look at the cost of health insurance, fee-for-service health insurance versus a managed care, you can follow the curves over the next several years. I'm going to say about 10 to 15 years. And they were parallel, but they were about 20% lower. Premiums were about 20% lower. So companies were really interested in doing that. But what happened later on, when fee-for-service started to go down and the HMOs started to rise, and the HMOs like Anthem or Blue Cross, like United Health and Humana and others, the big five, they started buying smaller health insurance companies. So now you have a virtual monopoly, but there is no monopoly in the insurance business because it's not regulated by the Federal Trade Commission, right? So right now, this is why health premiums are skyrocketing 15 to 18%, 20% in some cases. And that's where we think is the sweet spot, because we can go to companies and say, you're being basically killed with health insurance, and nobody tells you how much that you're going to utilize. They say, well, because of what you've utilized, they don't give you the numbers. They have them, but they won't give them to your HR director. Basically, they'll just say we have to go up by 50, 18%, whatever. And then they just compete with the other. So maybe they'll take you for 2 years and then slip over to somebody else. That's the dirty little secret.
Yeah. Dr. Campbell, I see your hand up.
Yes, Dr. Westbrook, excellent presentation. I think you're one of those rare birds that has a deep, deep fund of knowledge, and you've integrated it and can explain it. I was wondering, in your journey, when was it that you decided the healthcare delivery system was broken? What book did you read, or who did you talk to? When was it? And how did you start on this journey? So how long have you been at it?
That's a great question. Well, over 25 years, I got to know, well, I'll tell you, I'm going to tell you a little story because it's interesting. It was Mother's Day, and I had my mother here for breakfast, and I get a call from this family doctor from Norwalk, Ohio, small town in northern Ohio, Dr. Nino Camerdes. And he said, I read your article in Dayton Medicine, which is the journal that was published monthly. One of the few, I don't think it exists anymore, but one of the few periodicals that went to Ed Annis in Florida, and he read it. But anyway, Nino said, I read it, and I think you have a gift. I think you need to get involved. That was the start of my involvement. Within a year and a half, I was running for Congress. And based on my interest in getting free market healthcare back to the norm again and to change this system that has gone so wrong. So that's kind of the micro story.
Excellent.
I think my passion goes back to the early days. Semmelweis and his struggles, Aerosmith, Sinclair Lewis' book, really got me into medicine in the first place. And I see it now going in the wrong direction. I was going to put on a video. There was a video that was a series called New Amsterdam. And this ER doc, the director of the ER, is going around. The computers are down, and everybody is scurrying around and saying, oh my gosh, what are we going to do without the computers? And a resident comes up to her and says, doctor, she says, I've got a patient with abdominal pain, but the computers are down, and I don't know what the differential diagnosis is. And she looks, she said, you're a resident and you don't know a differential diagnosis for abdominal pain? And then another assistant comes up and says, how are we going to give so-and-so a prescription? She says, well, try this little pad. It's called a prescription pad. So this is where we've arrived. People are really clueless. And so we're practicing medicine by internet. We're practicing medicine by what the book says. That just isn't right. Best practices. Those kinds of things gave rise to the COVID crisis we have now, and everything is now determined by some bureaucrat that's not even a virologist or epidemiologist who runs the show. And so he is now the god of the COVID area.
Yeah.
So,
to kind of flip that a little bit, I was going to say, so did Dr. Campbell, comparing notes for a little bit, what was it that kind of got you up and on your high horse like Dave here?
Yeah, I was, it was really when we began having drug shortages. I'm an anesthesiologist, and I couldn't understand the drug shortages. And I actually went down to Washington to an FDA conference, and I ran into the business editor of the Wall Street Journal. We had a cup of coffee, and we kind of just started doing some things. And I think I came to realize just how broken our healthcare system is. And so that was the first thing. That would have been like in the year 2008. And then fast forward, I kind of thought that we were reaching a tipping point where doctors would stop being complacent. And we had this idea to start this group called Free to Care, which was about healthcare freedom. It's about the doctor and the patient being at the center again. And I thought we might get a few thousand members. And we started April 1st, 2018, and we're now up to 90,000 doctors.
Wow.
Who think that we just simply, the system's broken. So I guess I underestimated how, I knew the system was really broken, but I underestimated the awareness of it amongst our physicians. So I think we're going to reach a tipping point. We're either going to have socialized healthcare, or we're going to have an alternative that works, that's not 18% of GDP and you can't see a doctor. That's what we have right now. So anyway, but thank you. And I'd love to be in touch with you at some point. I love to connect smart people to smart people and let them do great things. So maybe we could do something like that.
You know, it's fun to hear what you're saying, because I remember from this plan that Charles and I, and even before I was involved with Charles with it, and I was out and I was working with a doctor, and he had been almost sucked up by the Cleveland Clinic, and he managed to escape. And so I was working with him in his little private practice office. I explained this medical cost sharing approach that he could make use of, because he was trying to just be cash only, but here was a way a patient could kind of make it work both ways, and he was loving the whole thing. So when I got all done, he looked at me and he said, "You mean that's going to allow me to be the doctor again?" He was like in his mid 60s. So, you know, it was great.
Yeah.
But and then he looked at his couple office people. He says, "Why would we not do this?" And they all said, "This sounds fantastic." Then, of course, being on the sales side of it, he said, "Hey, if I organized meetings on Saturdays and had all my patients come in, would you be willing to come in and tell them what this is all about?" I said, "Can we start this Saturday?" So, yeah, we had a lot of people jump on it because it makes good sense, and everyone's a winner when everyone gets back in control, for sure. You know?
Exactly.
Charles, I see your hand up.
David, I just want to thank you for alluding to Sinclair Lewis. On this other webinar Jeff and I host earlier on Wednesdays on various liberty issues, we had Shakespeare professor Paul Cantor from UVA talk about a side project of his teaching political economy via literature. And this is something A.T.L. Mencken was very much into at the turn of the century. And people into this really know there are a handful of authors that will teach you how the world works, political economy, liberty, if you read them. Theodore Dreiser, Joseph Conrad, Willa Cather, and Sinclair Lewis, all his books. I have that book, Aerosmith. I'm gonna read it. Do you remember what specifically about Aerosmith was so life-changing? Because Sinclair Lewis, once you get into him, that guy is incredible, his books.
He's a good novelist. Unfortunately, he was a socialist.
Uh-oh.
That I learned much later. I loved his books, but he was the one that pushed the idea to Roosevelt to start Social Security. He was a major player. That started in California, the left coast. And so that's, and again, that doesn't change my opinion of his book or of, the character, which I admired greatly. Yeah, that's the point. Physicians, that's our life. Now, it's not our entire life, but it's a good portion of our life. And the idea is that we have service to our community, to our patients. We're losing that. We're losing this idea that hospitals are there to serve the public, not to make more money so that they can give more bonuses to their administrators. Or insurance companies become billionaires. To me, it's unconscionable. But everybody's, a lot of people seem to be going along with it. It seemed to be really seem to be satisfied. They don't like the cost of it, and they don't like how much time you might have to spend with their patients. I can tell you the morale amongst doctors who work for hospitals is at an all-time low. If it wasn't for the financial incentive, they would be out of there, and that's where we want to bring them in.
Jeff, if I could follow up, Charlie here.
Please, yes, give us the last question due.
Well, I wondered if Paul Roberts would be interested in giving a quick comment, since he is shopping his documentary around on diagnosing healthcare. And then finally, if you want to give a last word, Dr. Westbrock, about the future of healthcare. I mean, Jeff and I work with doctors unhappy, like you state, to develop their cash practices, and we're trying to coach patients to be effective cash shoppers. But it's an uphill battle. And before you comment on that uphill battle that we're seemingly both engaged in, I wonder if Paul Roberts wants to kind of give a quick 2 cents on what you presented and what he's doing. Paul, are you unmuted or?
I gave him the unmute request.
Well, meanwhile, why don't you go ahead and comment on that uphill battle of getting doctors and patients to meet together around a cash price?
Well, it is an uphill battle, but I will tell you that doctors that I talk to are excited as can be. Doctors are going out in primary care, particularly, and they are doing very well. Concierge medicine and direct patient care are areas where doctors seem to be doing very well. I've seen 2 or 3 now who within the last 6 months have started their practices. One doctor told me that he was working for one of the hospital systems and it was going very well. You know, had patients that were dedicated to him. And the hospital came to him and said, you know, doctor, we want to change, we want to move your office assistant out. We need to put her in a different practice. And he said, well, that's my sister. He said, well, no, that's okay. We want to do that way. In fact, we're going to move you out of, you know, the local area, you know, north of town where you are. And he said, no, you know, sorry. So he went into practice. He's happy as a clam now. He's doing private practice, fee for service. I think doctors got a taste of it. The problem is they worry about their incomes. You know, we are so concerned about how much money we make every year and keeping our houses, you know, doctors were encouraged to buy a big house, buy nice cars and go on nice vacations. Well, that has a price too, doesn't it? You have to see so many patients or the hospital might let you go. I think I'm very optimistic. I think doctors are going to realize that the only way they can get along, if they're good doctors to their patients, to take care of them in the way they want to do it, they will get the message. But they've got to be able to make the money, and that's what we're going to do by bringing business to them. They charge fee for service. We say charge for fee for service. We're not going to discount your rate. You charge what you feel you're going to charge. We take a small fee, period.
It's down to, and everyone's willing to pay it as long as all that extra stuff isn't added to it that you just visualized. So what a great place to end it for the day. Sadly, we've run out of time here, but I definitely want to thank you for being here today.
Thank you. I appreciate it.